Okay, yes. I try to concentrate on a few of the topics in the pediatric spine. So first of all, how did we get here? How come we have so many complications in a pediatric spine surgery? Perhaps highlight some of the high-risk groups, have a closer look at some of the bad actors, and what can we do and what do we know really objectively about minimizing these complications and how we treat them. So no question, spine surgery, one of the surgical fields with the highest complication rates, or what we would like to call them adverse events, and it's particularly so in a pediatric spine surgery. Yet, the surgery is clearly the single greatest therapeutic tool to deal with these significant deformities we see in children. No other technique can address a deformity like this other than an operation. The child is a gibbous secondary to myelodysplasia. You can see with the exposure, you can work right around the spine, and you can actually make a difference in a child's life, correcting that type of a deformity. It is really the dramatic expansion of the scope of a pediatric spinal deformity in the last 30 years or so, which has allowed us to previously untreatable or only marginally treatable condition. However, it did come at a significant price. This multi-headed monster of complications, also we like to call adverse events, has soon arrived on the scene. We see wound infections, we see other system infections, a risk of neurological injuries, all is there. We see neural disruptions, significant blood loss, cardiac and pulmonary compromises, and failure of fixation or our instrumentation and fusion. And iatrogenically, we can operate on the wrong levels, have add-on deformities, as we already heard lots about it in the adult population, but we do have these in children as well. So it hasn't always been that way. When I trained in Toronto in the 70s, and I did my fellowship and started my practice at Sickets in 1981. Harrington rods and wire instrumentation for the front were pretty much the only instrumentation available. It was at 1981, then the Eduardo Lucchi was first introduced truly segmental instrumentation. We did not have spinal monitoring easily accessible, and Stagnara wake-up test was the gold standard. And we had relatively low infection rates. There were some pseudarthroses, and the correction was only really unidimensional. It was either distraction or compression. So many of these kids were left untreated or undertreated.
Sorry, you know, I don't mean to embarrass you, but I'm a rather brilliant surgeon. Perhaps I could help you with that hump.
What hump?
So how did we get here then? You know, the dramatic improvement in pretty much everything from the imaging techniques, spinal cord monitoring, pharmacological and mechanical control of blood loss, improved treatment of comorbidities, and of course, us surgeons pushing the envelope has placed us where we are now. However, the nature of the beast really has not changed. You still need long exposures, prolonged procedures. We're putting an increasing foreign body load into the patients, both metal and allograft. We are getting ever closer to the major vital structures such as the spinal cord, blood vessels. In other words, we operate in a tiger country, frequently anatomy which is far from being normal, with abnormal neural elements, significant blood loss, almost inevitable, and kids who have a poor soft tissue envelopes and multiple comorbidities. So consequences of this is, of course, that if some of these things happen, the procedure can double in time. You have a prolonged hospital stay. The eventual outcome can be significantly affected. Additional surgical procedures down the road, and in the worst case scenarios of long-term disability and perhaps even death. And clearly this costs a lot of money to the system and the patients as well. So what is the scope of the pediatric spinal deformity? Clearly, the relatively straightforward, although there is not that straightforward, are the idiopathic deformities. But what really is the big issue is the other etiologies, like the congenital one, the syndromic ones, and the neuromuscular, which is a significant portion of the pediatric spine surgeon practice. And of course, essentially the last frontier, the early onset kids. So there is a study which is already a number of years old, but it probably holds and looks at the children with a CP and their complication rates. There was a 25% complication rates in this study, with 8.3% of reoperation. And all the way down the line, you can see a pretty significant complication rates. So look at some of these bad actors individually. So infection, clearly, the big one is the deep early infection. And it happens fairly frequent in a pediatric age group, certainly at the high-risk group. That is the neuromuscular kids, the kids who require extension into the lower lumbar spine and the pelvis, kids who have bowel bladder incontinence and whose skin is colonized with all kinds of flora and fauna. Because of that, a lot of these kids have gram-negative organisms, and in the study by Jabbar, Abdul and Jabbar, almost 20% of these children had a gram-negative organisms. So what is the objective evidence of regarding infection in the pediatric spine? Certainly the neuromuscular etiologies, particularly the myelodysplasia, have a high rates, increasing fusion length, and a number of anchors contributes to it. Length of the procedure, pelvic fixation, blood loss, and previous multiple operations and reoperation, certainly very common in treating the early onset scoliosis. Nutritional status, and the worse the deformity, the more likely running into an issue. Myelodysplasia is a particularly bad actor as far as infection rate is concerned. There's some of these older series. You can see there was, in the series by John Hall, there was a 67% chance of infection, and associated with the high rates of pseudarthrosis. So not an unusual picture. A patient like that I had to deal with when I moved from Toronto to Portland many years ago. There was a whole slew of patients who basically had these type of infected pseudarthrosis problems. Clearly not surprising if you have to operate through posterior tissues like seen in this picture. My approach, of course, is to use anterior approach to stay away from that type of skin. So how can we prevent some of this or minimize at least the infection rates? What is the objective evidence? Antibiotics clearly play a major role, and we'll address that shortly in a little bit more detail. Significant blood loss can be to some degree ameliorated. Change the approach. The anterior approach certainly has a lot less infections. We use occlusive dressings, at least for the neuromuscular etiology patients. That seems to help. But no evidence regarding drains. Perhaps for the neuromuscular patients, we always use these. And You can see that doing a myelodysplastic patient doing a completely anterior approach gets you away from operating through that horrible soft tissue in the back and get quite a good correction through a sort of a double thoracotomy approach. So what about the antibiotics? I think the biggest improvement in the last several years have been using the intra-wound vancomycin. You can see the numbers. They can drop the infections almost by 1/10 to a 1/10 incidence using intra-wound vancomycins. And it, of course, can result in a very significant savings in terms of money during the child's hospitalization. So what's the best practice evidence at the 2017? Certainly gram-positive and gram-negative coverage for the neuromuscular kids, antibiotics within 60 minutes of prior incision or redosing. You have an intra-wound vancomycin, and at the end of the procedure, wound debridement, standardized protocol for closure of the wound. And there's some good evidence that the team approach also helps. So what about neurology, the complications which affects the central nervous system? And this could be certainly a devastating complication to the patient and the team. So the high-risk situation for that type of a problem, underlying spinal cord abnormalities, which we see not that infrequently in a congenital scoliosis. We have a complex deformities, like an NF-kid picture over the, on a slide. Kyphosis is a high incidence of problems. And of course, the more invasive radical procedure and can increase the chances of neurological deficit. And clearly, the thoracic location is worse than the lumbar or thoracolumbar. So it's significantly worse in a pediatric spine surgery than in adults, about 60% higher incidence of neurological risk. Particularly the congenital and neuromuscular kids, kyphosis correction. When you start doing some more complex procedures such as osteotomies, certainly the risk increases as well. If you have a child who already is compromised, it's almost prohibitive how high the risk can be. So the real bad actors, the osteotomies, the revision surgeries, kids with a baseline deficit and pre-existing dysraphism in the spine. You can see the operating on the spine like that, like this child with a metatropic dysplasia, when the spinal cord is really just a shoelace, and the child has a neurological deficit to start with, is a challenging issue. So intraoperative neuromonitoring, of course, has been a major advance, and it's absolute prerequisite for the modern spine surgery. However, it's not the only thing which can minimize the complications. A detailed pre-op history and physical exam, together with good imaging. And lately, what has really become pretty mandatory for some of these complex cases, that is the 3D intraoperative imaging, has becoming a gold standard. Robotics, true robotics, is also on the horizon. Approach modification is also an option. We frequently use the halo traction to get as much correction as we can preoperatively. Sometimes you do have to accept less correction. New technologies help, such as the magnetic rods, or for treatment of early onset scoliosis, or a Vector helps together with this team approach. However, occasionally you just have to pass on some of these. So if you have a neuromonitoring alerts, something we all dread, of course, always assume that it's a true cord pathology before you rule out all these other things. And it could be either mechanical, related to the implant placement, or a correction maneuver, as we heard already today a bit, or ischemia. again, usually by the manipulating the cord or causing a buckling in a cord. So the protocol is very clear. The single goal of the whole team is to get the signals back to baseline as quickly as you can. So rule out the other issues, have the anesthesia, get the anesthesia on board, and of course the surgeons reverse the last maneuver, remove implants, check for any bony compressions, remove the hardware unless it's absolutely necessary to stabilize the spine, decompress the cord, and if worse comes to worse, abandon the procedure, optimize the systemic conditions, and try to get a child into a urgent spine cord imaging, such as MRI or a CT, to see if you can recognize the problem. We do have a posted checklist, what we do when we have a abnormal sickness in the operating room, and I think these should be in every spine surgery room. Briefly, CSF leak, probably highly underreported incidents. You certainly, operating on kids with neurofibromatosis, all these connective tissue disorders is highly viable, and a complex anatomy, it certainly can happen. How do you deal with this? Optimally, you close the dura primarily with the suture and a sealant. If it's not possible, grafting is an option using all these variety of dural substitutes and sealants. We use drains and the last resort, a shunt. We try to close the wound as tightly as possible using skin glue and keep the children on bed rest for 2 or 3 days. The bad actors, of course, the kids who leak CSF post-op, if it could be even worse if they get infected, or the kids who leak into the chest. I've had that only once, and it adds on significantly in terms of hospitalization. They need chest drains eventually, etc. What about the instrumentation placement? Very briefly, we put all kinds of screws, hooks, cages, rods, wires. So there's no surprise that there could be issues, particularly in some of these kids who have a very distorted anatomy, tiny or non-existent pedicles, and or they have a multiple previous operation where the loss of the anatomical landmarks is pretty much a rule. This made a huge difference in our practice. We now use this pretty routinely. Certainly for any complex spine deformity, but we pretty much use it routinely now, even in the adolescent spine deformity. It allows you to insert these screws into the anatomy you can actually see on the screen. Lastly, I want to mention the mortality. And this is really a major issue in early onset scoliosis. It was Bob Campbell, late Bob Campbell, who developed this concept of thoracic insufficiency syndrome. And a lot of these children are really fragile population, and the mortality is quite high. John Smith and Salt Lake City collected cases from Bob Campbell and other institutions, and came up with 17 deaths in about 300 patients, and variety of etiologies. Those were all kids early onset with thoracic insufficiency. And so you can see the mortality in the children is about 5.4 per 100,000, but it was more than 100 times higher in this specific age group. So it is a tricky area, not certainly something for a casual operator. We can take some hint from this particular sign on one of my favorite ski runs. I think the most important one is to do not ski alone. The spine surgery team is I think, essential for some of these high complexity cases. if you have this multi-headed monster, bring on a team, and so you can deal with some of these nasty heads one at a time. And it involves preoperative assessment, surgical team, and of course post-operative. Build these teams in your own operating room. Build them from the bottom up, not by some decree from above, to get the capable and trusted people onto your team. So thank you very much for your attention.
I like that last slide. That reminds me of the concert we saw together many years ago. Yeah.
No, I mean, it was a great overview of all of the complexities that we see in both pediatric and adult surgery. I think I like your idea of don't ski alone. I think it's a nice, one of the things, particularly for young surgeons or even experienced surgeons, is when you're in the heat of battle and you lose signals or you have something catastrophic happen like a dural tear that you feel like you can't repair, it's very easy in those situations to become overwhelmed and then not be able to make decisions you need to. I would just like to re-emphasize that one of the things that I've done even now, and I have a little bit of experience under my belt, but if I have a problem in the operating room and I'm struggling to come up with a quick solution for it, what I'll do is I'll just stop and call one of my partners and just explain the situation to them. And it's amazing how thoughtful someone can be outside the operating room and give you a nice, unbiased approach on how to deal with the problem. It is just incredibly calming. And as we get older and we worry about our cardiovascular health, I think it's important to make sure that you do that as much as possible. So I just encourage that for the young surgeons in the room and in the audiences. Don't be afraid to ask for help. I don't think people are in general mostly just flattered that they're being asked for help. They are not going to be rude or anything else, and usually they give you some pretty helpful advice.
Yeah, underline that. So take your own pulse first, as I say, and then, it's not a sign of weakness. In fact, it's a sign of confidence to ask somebody else to come help you. So, JC, do you guys do pediatrics at your?
No, the youngest that we've done is 15. I mean, we do see sort of the adult ramifications of either uncorrected or corrected pediatric deformity surgery. And I think what's really striking about it, and you only need to look at the MRIs to see it, is in adult surgery, we are typically dealing with, our complexity often comes from prior surgical interventions, versus in pediatrics, you guys really have to deal with very abnormal anatomy. And I think that the solutions that you have to come up with are quite a bit different than those in adults. And I greatly respect the work that you guys have to do in managing that.
Yeah. Well, and speaking of the team, I've for many years have teamed up with my good friend who is a pediatric neurosurgeon, doing some of these complex cases, particularly in the neck, and it's invaluable. I don't think we ever had a significant complication doing it, two of us together. Yeah.
Can I ask, the early onset scoliosis you were talking about, the magic rods or the growing rods that don't need to be revised as often, has that finally, because it is, I think the two unsolved areas of spine surgery right now, the biggest ones, number one is the aged spine and elderly spine, and the other is the infantile spine. Has that been as transformative as we might hope it would be?
Well, I'm glad you asked, because it is one of my favorite areas, and I feel very strongly they made a huge difference. A lot of the studies recently have showed that there's still significant complications, even with the magnetic magic rods. My feeling is that because they are not being used the way they should be. I was very lucky that I was probably the only person in North America using what it was called the Phoenix rods, which were magnetic rods designed by this French aeronautic engineer who we became very good friends with. And he had two principles. He had little toggle joint on each end of the anchors, which allowed for some motion. And it was a rod which was lengthened by a magnet rotating on the surface of the spine for the patient. And the parents were given the magnet, and they were doing 2 turns 4 times a week or something like that. So it was very slow distraction. With the standard lengthening rods, it was only operate every 5 or 6 months and stretch it as far as you could. It led some neurological issues, plus it led to stiffening of the spine, and they had this law of diminishing results. It was basically making a spine scarred up. So Arno, this engineer, unfortunately died in a plane crash. He was a pilot also, and he was piloting the craft which he died in, and the rod sort of died with him. So I at least apply some of these principles to the magic rods. Clearly, we cannot give this machine to the parents, but I have them come in every 4 to 6 weeks and lengthen just 2 millimeters. We set it 2 millimeters, nothing more. And both my partners, Michelle Wellborn and Dan Boughton, adopted the same thing, and our complication rates are minuscule compared to what the literature reports. I think we have presented some of it in a couple meetings. I had a presentation, one of those virtual SRS meetings during the COVID on that particular topic, looking at our complication rates. And I think it is primarily due to the fact that we adopted this smaller frequent distractions rather than trying to stretch the spine as hard as you can.
Okay, I'd like to ask, we had a nice, robust discussion last night about orthopedics and neurosurgery and the co-training that goes on there. Pediatric spine surgery is kind of left into this bastion of the pediatric surgeons that also do hip and knees and shoulders and everything else. What's your opinion on, as the surgeries that we're doing for these children are now more and more complex? They require more and more intradural, or maybe not intradural, but certainly intracanal work as we start removing vertebral bodies, placing screws in smaller and smaller pedicles. Do you think that that should be a combined adult and pediatric group? Do you think the pediatric group that does a little bit of everything is still appropriate for those most complex surgeries?
Yeah, a very good question, and I think we all sort of struggle with that approach. And when I first started, pretty much every pediatric orthopedic surgeon did Harrington rods. I mean, you could do it in 2 hours. The most complex thing was taking the bone graft from the iliac crest, and that was it. But I think with the increased complexity of the spine surgery, there is no room for a casual operator on that. And I think my sign on the thing is, this is not something you do every day. You shouldn't be doing it. And I'm not necessarily saying that it has to be a person who should be versatile, both in adult spine deformity and a pediatric spine deformity, because the adult spine deformity does introduce whole additional issues of comorbidities, which the pediatric guys are not going to be familiar. Plus, the techniques are different as well. So, but I think it should be a subspecialty of pediatric spine deformity, and that's pretty much all you do. And I mean, we have been fortunate enough in Portland that we have 3 people. We actually have 4 spine surgeons. 3 of us, I have now clinically retired about a few months ago, do 90% spine surgery. Actually, one of them is pretty much 100%. I used to still do a little bit of tumors and limb deficiencies, rotation plasty, that type of thing. And Dan Boughton, who is the third sort of leg of that stool, does some hip open dislocations for some of the adolescent hip issues. But we are the rest of the group, which is another 5 or 6 surgeons, do no spine surgery. So I very strongly favor being subspecialized in the spine. Yeah.
something we're all passionate about. I put in an editorial, orthopedics, please consider making spine a greater emphasis in your training, if you're going to do spine surgery.
And I tell you, one of my best education when I was a resident was 6 months on neurosurgery, because that taught me the meticulousness of the approach and the patience. Patience is not one of my virtues, but for the spine surgery, you got to have it. You cannot hurry those things.
Well said. Very well said. All right. Well, we are coming into the